for the semester for the Africa Initiative. The Africa Initiative in Syracuse University is a project which seeks to advance ideas in relationship to Africa, African peoples, and it supports to highlight research and publication in all areas. Africa Initiative is interdisciplinary in the arts, humanities, social and natural sciences, mathematics, engineering, and other fields. Now, this initiative is drawing oxygen from the energy of the students in Syracuse University and the faculty who have an interest in working on Africa. This initiative has been going on for about 10 to 15 years, building on the long traditions of Syracuse University and its relationship to Africa. This initiative is located in the Department of African American Studies. And at Syracuse University, the Department of African American Studies is a space for academic research and other works on Africa, the Caribbean, and North America. And it seeks to advance a Pan-Africanist view and a Pan-Africanist vision. By providing an alternative platform for constructive discussions in Africa, the Africa Initiative is helping to alter the dominant perceptions of Africa as a continent and to highlight the struggles of African peoples and African intellectuals. Today, we want to welcome everyone for this discussion on disparate effects of COVID-19. COVID-19 has had a devastating effect on the entire planet, but much more devastating on African descendants in Africa and in all parts of Africa. When I saw Professor Edwards' article in the monthly review, I said, well, I would want to make sure that our students and faculty get exposed to Professor Edwards. So I want to thank Mahi for being persistent in ensuring that we got Professor Edwards from Providence, Rhode Island. I want to tell her that I have very deep, close ties with Providence because my father is laying right down there in Cranston permanently. I want to also welcome Dr. Firew. Thank you so much for joining us. She's an assistant professor of emergency medicine at the Columbia University Medical Center and a special advisor to the Minister of Health in Ethiopia. Professor Firew received her undergraduate degree in biochemistry and molecular biology from the University of Georgia. That is in the United States of America. That's Georgia in Atlanta, in the United States. She then received her medical education from New York Medical College, completed a residency in emergency medicine at New York University and Bellevue Hospital, and a fellowship at the Columbia University Medical Center. During her fellowship, she received her master's in public health from Columbia University in Population and Family Health, along with a certificate of humanitarian assistance. Dr. Firew, thank you so much for accepting our invitation. I think it is in the spirit of solidarity because the Africa Initiative is run on volunteer basis on students and faculty without any major, let me say, imperial funding. Let me be very clear. And so we are very thankful for both of you for accepting our invitation to participate in this discussion and to share your knowledge and information with us. Please, Dr. Tsion, I hope I didn't mispronounce it. Could you please lead us off in the discussion?
Thank you very much. I appreciate you guys for being here and also for the invitation. I'm truly honored to be here. When I was at the University of Georgia, I used to be a member of the African Student Union, and seeing how that has grown over the years. And when Mahadra sent me the invitation and also explained that, we don't have the funding for it. And I've been there, I know how it is. And this is something that I gladly would do, and I would not expect. This is like coming home for me. So I gladly accepted, and it's great to see everyone for being here on Friday. So I'm going to discuss a bit. I'm going to share my screen. I know I have about 20 minutes, right? Okay. So because it's only a 20-minute discussion, I'm really going to talk about more of my work here in New York, and maybe touch a little bit about what that has also led to some of the work that I've been doing in Ethiopia. But to do those two things combined, it would take a while. So I'm just going to focus on this, and at the discussion, and I can dive in more on the work in Ethiopia too. So let me just give me a second.
Dr. Firew, you have access, right?
It's telling me host disabled participant screen sharing. So
I'm going to make you co-host so that you can be.
okay, you're mute now, Mahadra. Sure.
So I just made you co-host, so you should be able to have that option.
Okay. Let me just make this. Okay, can you guys see my screen?
Yep.
Okay, great. So in addition to the title and my job, and as an emergency physician and also as an advisor, I ended up obtaining, I think, the most important title about 6 months ago. I became a mother. So you might hear my kid in the background, so please excuse that. So I have a pandemic baby, and I think it's becoming such a common practice now with working from home and virtually presenting. So that has given us the opportunity, but also comes with some consequences of, background noise from the back. And I think most people who are parents here to young age children could relate to it. So I'm going to really talk about the lessons from New York City, and which is once the epicenter of COVID-19, and mainly talking about my experience here working at Columbia University Medical Center. For some of you guys who don't know, this is it's located in Washington Heights, one of the most diverse area of New York City, mostly Hispanic patients, Dominicans, and this hospital combined between those three hospitals. So there are three hospitals that are under Columbia University Medical Center of New York Presbyterian. And between these three hospitals combined, we see 250 patients annually. So they're tertiary hospitals in the community, and they're really highly specialized with triple organ transplant patients and all those kind of things. So, and, just kind of going back what it was like for us back in March and April of 2020, we were seeing the numbers in China, we're seeing the numbers in Italy. And, unfortunately, I think among many people, maybe not so much for me, but I think it was just more like us versus them. We're like, it's not going to come to US. People were like really interested in what was happening in Italy and China, but most of us felt in a way we're immune to it from arriving here in the US. And just to make another parallel thing, I think in a way I'm very proud about most of the African countries. I remember when before WHO declared it pandemic, when in January, early January, when WHO declared it as a public health emergency of international concern, I was proud to say that Ethiopia has taken most of the strides way earlier than what the US had done. Just to give you a contrast, I traveled to Ethiopia and also Sweden for the UN road safety meeting in February 2020. And then I traveled through Ethiopia and came to the US. And I remember at least at the airport in Ethiopia, there was questions of screening, having traveled to China or so. But then when I came to the US and also when I went to Sweden, there was no mention of that. And this is in February. So you can see some of the, the screenings and those things have been implemented. And this has been the experience, at least from what we learned in Ebola and from other outbreaks. We were so used to epidemics happening in lower income countries, especially in the African setting. I think we're much more prepared. So when I came to the US and back in my own community, there were people coming with respiratory-like illness. Of course, at that point, we did not know it was COVID. This is up to March 15. So I kind of wanted to touch more about how over time the volume of cases and the number of hospitalizations and the number of deaths increase. And I'm only going to really focus on the first wave. Unfortunately, we keep on seeing waves, but I think New York City was the hardest hit, as most of you guys know, during the first wave, and we learned from our lessons then. And I think it's just a diverse culture that we see in New York and most of the cities that when people travel between different places, the risk of people carrying it over to these areas were very, very high. So as you can see, the numbers are increasing from. So this is March 15, and I'll tell you a story of what happened on March 15. I was supposed to travel back to Ethiopia in March, and I got a call from one of my colleagues. Probably most of you guys would know her. As Lorna Breen. Unfortunately, I'll talk about her at the end, but she died by suicide. And she was a site director at the time. And she called me saying, the patient that you saw the other day who came in for a urinary tract infection tested positive for COVID. And she said, you've been exposed. And at that point, of course, the masks were not mandated in the hospital. And I couldn't remember if I was wearing a mask or not. So because of this high risk exposure, I had to be on isolation. And this is 2 days before I was supposed to fly out. I had no symptoms. And there were so many physicians and nurses who had an exposure and were told to stay at home. And the Department of Health mandated that. This is very early on. And but before we know it, everybody was being told to stay at home. So of course, policies changed. Like if you're not symptomatic, come back to the emergency department, because as you can see, the numbers were peaking. And this is for the number of the cases, not hospitalizations. And this was a case here also at our hospitals. This is the number of testing that we're doing and the number of tests that are testing positive. As you can see, starting March was more test availability. You can see that the positivity also increased. And along with that line, the number of hospitalizations, of course, lags behind, which around 2 weeks or so. And you can see sometime later in March, the hospitalizations start increasing in New York City. And also when you'll see the death 2 weeks later, from what we've seen, it peaks around early April. So just to kind of go back, so after my initial exposure, I didn't have any symptoms. So I went back and worked. Unfortunately, after we were seeing all COVID patients. So just to give you a bit of a perspective, early March to late March, we were seeing maybe one case of COVID or suspect. In a matter of 2 weeks, every patient that we're seeing were COVID patients. So was on, I believe, the 29th of March, New York City had the highest number of calls to the EMS system, to ambulance activated, and EMS would bring in and just put patients in the hallway. And I had a patient who was hypoxic with low oxygen, who was in the hallway, and I didn't have all the PPEs in front of me. I had my face mask and I had my gown, but I realized I didn't have my eye shield at that time, and I rushed to intubate this patient because he was not breathing on his own in a way. And I realized that I performed a high-risk procedure, and 2 days later, no surprise, I ended up having symptoms and tested positive. This was around early April. So it was during that peak time, and every patient, just to be the contrast, in a matter of 2 weeks, every patient that you were seeing were COVID, that they came in with low oxygen with fever and respiratory symptoms. And just to kind of paint the picture of what we were dealing with very early on, the ventilator supply is exhausted. And then when you think of, these patients are mainly respiratory issues, and you think of only respiratory apparatus, but that's not the case, because to keep this patient sedated, you need medication, you need a pump. So over time, those things were exhausted, and then also medication shortage. And all of a sudden, it just felt like this is a story that I keep on hearing, and this is experience. This is what happens every day in places like in most places in Africa, shortage of this, shortage of that. So really to work in that, and I always joke about how not joke, but I always mention how we became a, a center of excellence and center of high resource area, and in a matter of 2 weeks we went into a poor resource area. So that happened, and then the workforce shortage as people became ill and had to stay at home. So we were working with extreme workforce shortage, and unfortunately some deaths also occurred in our hospital, including from the mental health effects of COVID, including one by suicide that I just mentioned. And some of the challenge, speaking to your colleagues with a mask, it felt like you're screaming at them, but it's because they can't really hear you over the mask. We couldn't identify each other, so we had put our name tags, and some people put a picture on their gowns, on all those kind of things. So it was some creative stuff that we came up with to overcome the challenge. And this is just to show the amount of emails and briefings that were happening every day. Policies. This was a novel virus at the time, so we did not know about what we were doing, what was working. So everyday policy and change really required being resilient and versatile to deal with this pandemic at the very early on. And we also had to make some uncomfortable decisions about hypoxia patient, discussion with the family members. And the most difficult part was seeing patients by themselves without having a loved one, especially being in a very high diverse area with Dominicans and African immigrants. It was very challenging to see family members suffering without the support of the family members when this is really the center of the culture. And other things, I guess this is really going to the situation now, but so now fast forward a month and a half, a year and a half, it's still very difficult for me to fathom that with a vaccine available, with what we learned so much from early on the past 1 year, we're still overwhelmed with the collapse of the healthcare system. And this is happening in America. And this is not just because of COVID, it's just because we've had a fragile health system. And this was a tweet by somebody who recently on September 6th. And I just put the slide in because, people are like, oh, COVID is not that bad in New York right now, so you guys should be okay. But we're dealing with the aftermath, which is with the nurse shortage. There's a national nurse shortage everywhere. Unvaccinated people in the ICUs, and we have ICU full of unvaccinated COVID patients, then other people that would come in for heart attacks, for strokes, they won't have access. So because of that, people like me who work in the emergency department are working in an overly crowded environment than usual. And this is the worst I've seen my own emergency department because of those things. And nurse shortage for several reasons. People that were near retirement have retired. People have left for better paying jobs in other states because the COVID is really bad. So they're offering a ridiculous amount of money so people would go there. The third thing is people have really been burned out by the pandemic and how society has responded to this and have just left medicine. And when I went back from my maternity leave, I was so sad to see the amount of nurses that have left, and there were new faces every day when I went back. And this is the kind of the constant challenge that we faced. And right now, this, as you see from this tweet, this father had a 12-year-old who had an appendicitis, but because of the long wait to see his son suffer. And these are true stories. This was somebody who came, who was public about it, so I could share this, but this is what we see every day in our emergency department. There's a delay in care. And because the COVID cases are not as so bad in New York and some places, but there are other things that are at this point that are affecting the healthcare system in general. And in addition to the burnout, the mental health effect of healthcare providers. And this is just me sharing a bit of, Mahara wanted me to also share a bit of the story about vaccines and how I've advocated for it. And I was one of those people to be offered the vaccine as a frontline healthcare worker. Emergency department providers and ICUs were the first people to be offered in New York. So at that time I was 27 weeks and I was hesitant to get the vaccines. I was a vaccine hesitant at the point, only for 1 week. I spoke to my provider, I looked at the data, and even though I had recovered from COVID at the time, looking at the data that was available at the time, and also with the new variants that were coming, I made the informed decision to get the vaccine. There was a lot of questions, a lot of also, unfortunately, attacks from anti-vaxxers. But I've written an op-ed about it, and even now publicly speaking about this, and because there's a lot of vaccine hesitancy amongst people who are either pregnant or planning to be pregnant. Unfortunately, as you guys know, we're fighting a lot of misinformation that's going around. So this is me and my colleagues trying to infiltrate the different media outlets through providing and evidence-based information. And also the current data, there's a lot of questions about this, that the risk of spontaneous abortion or miscarriages compared to the general population among people that have received the COVID vaccines are, this pretty much is not, it's the same. So, and also to just say that CDC, especially now with a lot of the information from the past 8 to 9 months of especially healthcare as being the first ones to receive this vaccine, they do follow up. They called me during my pregnancy and after to see if there was any serious outcomes. So they're getting information from real people, real data. I know there's been a lot of, especially with the prior administration, there's been a lot of issues with the CDC's transparency and accountability, but this is to say that a lot of this information are now gathered from real people, so I can vouch for that. And other things I would say, I've, very early on now when I walk in the city, I see people offering COVID vaccine in every corner, and that was not the story like how we've changed in the past year and a half. This is a story of how I struggled getting testing back in April of 2020, and I was very verbal about it. And unfortunately, at the time, there was a tiger at the zoo who got the COVID test, and there were colleagues of the prior president who were getting tested just to know, but without known exposure. So really seeing the discrepancy and the injustices that were happening around that and being very public about it. And again, trying to teach the public about some of the misinformation and also some of the challenge that healthcare providers were facing. And this is really about the outreach and advocacy work, in addition to the real, the care that we're doing in the department. I think since this is an academic institution, and there's so much about doing publications on high impact journals and on medical journals or on public health journals, but I feel like what I've learned in the past 1 year, the real impact comes really from the outreach and advocacy work that you do in the community. And people have reached out to me through social media, through emails, calls to ask questions. There are people like, hey, I know that you got vaccinated for this, and I heard your interview on this, or I read this, and could you please help me answer this? I'm just worried about this thing. So I think during this pandemic, one thing I've learned is really about the outreach and advocacy work that we as informed clinical providers and as people who use the evidence and as infiltrators of the truth could be very, very powerful and monumental to have a big impact and change when it comes to informing people with the correct and right information. So I'm gonna conclude my talk in memory of colleagues and many others that we've lost. This is to say that Dr. Lorna Breen, who was one of my colleagues, died unfortunately by suicide the end of April after suffering after being ill with COVID, and also consequently as a medical director, seeing all the challenges and after witnessing all of the outcomes of our patients, she unfortunately had really felt the mental effect of the pandemic, and her family has been very vocal about it and recently took it to Congress, and they were able to pass the Lorna Breen Act, which is offering mental health, and also make sure that, for some of you guys who don't know, healthcare providers who seek mental health, there could be very negative consequences on their on our career. So unfortunately, it's not something that we're able to do and with the safety net that's around for many other people. But because of this pandemic, it was great. Even though I don't like the word hero, we were praised and hailed as heroes, and we turned from heroes into villains now over a matter of few weeks to months because of the vaccine mandates. You're trying to speak the truth, and all of a sudden you're called, you're just the virus is a hoax. So you're being attacked in various ways. And especially I, as somebody who lived in Georgia, the state of Georgia in the South, and had a lot of family and friends there. Unfortunately, the uptake and the information there has been very, it's been more with the misinformation and unfortunately a lot of conspiracy theories. So I've gotten several of those personal attacks. But just, when I speak of COVID-19 and what is happening to our emergency department and our healthcare in New York and all over the US, I can't finish without really speaking about many of our colleagues and many others who died because of COVID or from the mental health effects. In the past 1 month, unfortunately, 2 other nurses that I've worked with have died by suicide too, and this is just the tip of the iceberg of what we're seeing. So I just wanted to be able to speak and mention that for many of you guys here. So that's about it, and I think I will stop maybe after saying, since I have 1 minute, just saying a few things about what has been the response in Ethiopia. So Ethiopia, as like in many African countries, the COVID cases, the percentage of positivity is not as wide as, as severe as what's been going on in the US. And of course, it could be the blessing because we have such a young population, but also there's a lot of testing that is not widely performed because we just don't have the capacity. So that's been the case. But now the ICUs and also the isolation centers and the COVID treatment centers are now filled with patients. Ethiopia is currently undergoing, like many African countries are undergoing a 3rd wave. But I would say because of the early actions that were taken that I mentioned earlier, I think we're able to avert death and disability, especially with all the screenings that were happening very early on, as early as January and February. And also because we're so used to, outbreaks, epidemics happening with, there's cholera outbreaks happening. And from what we've learned in West Africa from Ebola outbreaks, that's been a lesson for many sub-Saharan African countries. And also great leadership. Our minister has been at the forefront from the very beginning and engaging multi-sectorial approach to COVID pandemic. At this point, like so many of us around the world, there is COVID burnout and exhaustion. People don't want to hear about it. Unfortunately, the misinformation about vaccines have also spread to many African countries, as we know. And that's been driven by, unfortunately, by conspiracy theories, coding religious things, and also because of lack of education and insight. The vaccine actually is now becoming widely available in Ethiopia, but the report yesterday from WHO showed that Ethiopia is one of the 10 countries in Africa that has less than 10% of vaccine uptake. But now the J&J, Sinopharm, and AstraZeneca, which are all WHO approved, are available in many health centers, especially in the capital city. So a lot of hesitancy, even from healthcare providers and workers. So that is a challenge that we're all going to be faced with for a while. But I can speak to and to say that we're a living testimony that vaccines have worked in places like in the Northeast, in New York, Vermont, all these places, the reasons that our hospitals are not flooded with COVID patients because of vaccines. So, and I always joke, I think most of you in this room can relate, most of us walk around with a big scar here. Some of my friends call it the fob mark. And I joke saying that, you know, if you have that mark, you can't be vaccine hesitant. So that's the kind of joke I tell, you know, my family and friends from the African diaspora. So I think all of us here could be the, you know, the disseminators of the truths and the evidence. So I think I am exactly at 21 minutes, so I'll stop. Thank you, guys.
Thank you so much. Thank you so much. This was such a moving personal testimony. Not only a moving personal testimony of the highest level of scholarly integrity, it was the kind of scholarly integrity that is very clear, to the point, that shared with all of us the challenges that people like you and other healthcare workers are going through. So your own journey as a patient, you're sharing with us what it means to work in an environment where there's burnout, to share with us what has happened to your colleagues. This was such a moving and very penetrating presentation. I want to really thank you very much for giving us this, and I hope you will stay with us so that in the discussion, some of our participants will be able to engage with you some more. So thank you, and thank you for also keeping time. Professor Edwards is in Providence, Rhode Island, and Professor Edwards is in the Department of Black Studies at Providence College. Providence College is one of the private colleges, and the gentrification of Providence means that the spillover from the bourgeois in Boston affects life and work in Providence. Professor Smith, her research examines the impact of colonialism and multiracial labor movements in state formation, state institutions, and long-term development in resource-rich countries in the global South, with a particular focus on Trinidad, which is called Trinidad and Tobago. Her work has been published in the Sociological Review, Political Power, and Social Theory. Last year, she came out with a very powerful statement on the impact of COVID on Black communities in the United States of America. And so we are so happy to have you join with us and share your research with us today. Thank you, my sister.
Thank you so much, Dr. Campbell. And thank you so much, Mahi, for this invitation to speak here today. I am really thrilled to engage in this very important conversation with all of you about this critical topic. Like Dr. Firew before me, I just want to take a moment before I jump into the material to acknowledge the over 4.5 million recorded COVID-19 deaths globally, including the more than 700,000 deaths in the US. I know that many people in this space here right now, Dr. Firew mentioned her own experiences with dealing with the pandemic. And so I know many people have been impacted, their health, their family. And so I just wanted to take a moment to recognize those enormous challenges that people are facing and continue to face, because it's ongoing. It hasn't ended, even though many colleges and universities would like to pretend that it has. So I will share my screen. And Can you see that? This, yeah.
Yes.
Great. Great. Okay, so over a year and a half ago, now we're almost going into 2 years since the pandemic first began and we started to see the first shutdowns. There were so many newspaper reports that Black Americans, Latinx Americans, and people of color more generally were disproportionately getting ill and dying from the disease. And to be honest, this really irritated me. I was lamenting the loss of so many people who were getting sick and dying, obviously, but I was irritated because the media, the talking heads, and even some intellectuals seemed to be somehow surprised by this. And, you know, to be fair, the data was really stark, right? The gap between the deaths among the white population and populations of color were large, and they are large, particularly between white Americans and Black Americans. But not only was this the case in the US data, but when you look across the world, you were seeing similar data coming out of the United Kingdom, similar data coming out of France, even though France doesn't want to collect data on race. We still have studies that point to these racial disparities in COVID-19 rates in France as well. And in Brazil, we were hearing the reports of this. So it was stark, to be fair, and it was global. But was it surprising? I will argue no, right? It's not surprising because this was our normal. This is our normal. And so this is what stimulated me to sort of write this piece that Dr. Campbell is referring to, which is trying to kind of shed light on the structural reasons as to why this has emerged and why this is the case, and to actually go beyond one of the more typical arguments that we were hearing from even sociologists at the time. And so that's kind of what I'll be touching on today to talk about. So how can we understand this racial pattern and who is disproportionately affected by the COVID-19 virus? The most prominent approach that we were hearing about, I think, and that we've all probably encountered is structural racism as an explanation, right? And to think in terms of structural racism is to move beyond thinking of racism as prejudicial attitudes and actions. And it pushes people to see that racism is built into and ingrained in the fabric of society itself, right? It is defined as multiple interconnected social institutions like housing, education, law, health, politics, employment, and so on, that institutionalize and maintain racial hierarchies and inequalities. And with regard to COVID-19 specifically, scholars were showing that these disparate health outcomes in the pandemic were the result of structural conditions under which people of color were living relative to the conditions under which white communities live. So COVID-19 fatalities occur more frequently among patients who have comorbidities, such as hypertension and diabetes. And within the United States, because of residential segregation, unequal race-based resource allocation, exclusion from housing, or housing and schooling in environments with much more pollutants, inadequate access to healthcare, all of these factors are drivers of comorbidities that render Black and other populations racialized as non-white more susceptible to COVID-19. And these are direct outcomes of structural racism leading all the way back to Jim Crow and redlining and indeed all the way back to slavery. And I'm not saying that this is incorrect. And in fact, I agree that this is very correct, but I think this is only a part of the story because these racially unequal outcomes are happening not just in the US, but in other countries in North America and Europe and in Brazil as well, just to name a few. And so it's happening. And if we look over time and more broadly, now we're seeing people in former colonies and in the global periphery more generally now being affected by the virus. And so it's happening to African and African descended people all over the world. So I think the structural racism lens is a little bit limited by the boundaries of nation, right? It analyzes white supremacist racial ideologies and racial structures as blocked opportunities within countries. And this might play out differently in different places. But what about the global connections, the historical interconnections that are happening? And I think the structural racism framework doesn't really allow us to see that. In addition, while it acknowledges the history of colonialism and racial slavery that gave birth to racist structures in the first place, there's very little engagement with the economic and production logics of why this is the case. The racial structures are not explicitly linked to economic organization or the relations of production, which I think are very important to understanding what's going on. And finally, I think this framework focuses a lot on race and racism, but less so on class and even less so on gender. But race, class, and gender are implicated. As we can see in the data, the even more disproportionate toll has been borne by working class Black folks and by Black women. And so we need a way to talk about these intersections that is grounded in history and political economy, right? So I argue that actually the literature on racial capitalism is a powerful lens that we can use to address these gaps. And this term is being proliferated in the social sciences more and more, becoming popular by Cedric Robinson and his seminal work, Black Marxism. But the literature, the overarching framework that looks at the relationship between racism and capitalism actually dates much further back to authors like W.E.B. Du Bois, Oliver Cromwell Cox, Eric Williams, Ruth Wilson Gilmore contemporarily, right? And so this literature generally just draws attention to the fact that there's mutually constitutive entanglements of racialized and colonial exploitation within the drive to accumulate capital. And so these scholars essentially are highlighting how capitalism as we know it today would not have been possible if not for colonialism, imperialism, racial slavery, expropriation, and labor super exploitation. And that is still the system we have today. The logics, those fundamental logics still persist. So with this literature, we are able to see the centrality of race to capital accumulation and centrality of racism to profits, because capital and capitalist states tie profits to what Lisa Lowe calls the social production of difference, which includes race and gender and nationality, right? Placing different values on labor from different groups of people. And this racial and colonial character of global capitalism facilitates the incredible accumulation of profit through the super exploitation of the so-called darker races of the world. And I will just briefly show, so I think this literature helps us to understand the common global history, the ongoing racist international organization of work, extraction, and production, and it also connects race, class, and gender, because Marxist feminists like Claudia Jones in the 1940s and many others today argue that Black women face a triple or interlocking oppression within the racial capitalist system, right, along the axis of race, class, and gender. And I'll just show you I'm looking at the time, right? So I'll just show you a quick quote, which is not very quick, it's kind of long, by Du Bois, but it captures exactly sort of the racial and colonial dimensions of capitalism. So he says, that dark and vast sea of human labor in China and India, the South Seas, and all Africa, and in the West Indies and Central America, and in the United States, are the people upon which the founding stones of a modern industry. They are despised and rejected by race and color, paid a wage below the level of decent living, and driven and beaten and enslaved in all but name. He goes on to talk about the materials that these people are compelled to produce, and all of these are gathered up at the prices, the lowest of the low, at fabulous gain in the imperial core. And it is out of the exploitation of the dark proletariat comes the surplus value filched from human beasts. And so I'm arguing that if we historicize the pandemic within this long arc of racial capitalism, we will see the mechanisms by which COVID-19 is exacerbating the already existing racial and colonial inequalities that undergird the global economy, right? So what exactly is revealed with this lens? We see that first, capital accumulation continues to be based on the super exploitation of Black, Latinx, Indigenous, Arab, Asian workers in the core and in the periphery. And I'll show you, for example, what New York City frontline workers look like. Just to touch on sort of Dr. Firew, some of what Dr. Firew is already describing in New York. But when the pandemic first hit and states started developing measures to combat the spread of the virus, which included lockdowns, stay-at-home orders, social distancing, masks, and so on, people were told to stay at home, but we still had food on the grocery shelves. We still had Amazon deliveries coming to our homes. CVS shelves were still stocked, right? Well, with everything except toilet paper. You remember that, right? But just to name a few. So who was doing this work? Who could not stay at home? Already overrepresented in the service sector, from transportation to healthcare support, food preparation and serving, to buildings and grounds, cleaning and maintenance, personal care and service. These predominantly Black, Latinx, Indigenous, Arab, and Asian workers have been required to continue working to provide goods and services. At the intersection of race, class, and gender, women of color were far more likely to have jobs deemed essential and at the front lines, like cashiers, custodial staff, nurses, homemaids, nursing home staff, and so on. Likewise, racialized workers from the peripheralized countries were being recruited into the core to help North American and European countries manage care and turn out even more profits during the pandemic. Women from Asia, the Caribbean, Central and South America, and Africa are a significant proportion of nurses, healthcare workers, and home care workers. In the food industry during the pandemic, while the privileged among us could stay at home and still get paid, hundreds of thousands of Jamaicans, Puerto Ricans, Mexicans, South Africans, and other people from colonized and formerly colonized countries traveled to farms across North America and Europe to keep food on the grocery shelves. So these people kept capitalism running, and they were compelled to do so in work conditions where their employers did not guarantee social distancing, did not give them personal protective equipment, and cleaning, sanitation was already a problem. So while viewed as essential, they were also treated as expendable, as they experienced greater exposure to disease, increased health risks, and paradoxically more economic precarity. Many of these people who don't get paid sick leave, they don't have access to healthcare or health insurance. And those who are undocumented still face the threat of deportation. So it's no surprise, right, that it is these very people, particularly African and African descended populations already living under the weight of centuries of white supremacy and structural racism who would disproportionately dying from the disease. And at the same time, billionaires continued to make billions, not millions, billions during the pandemic, both in the US. So here's kind of showing you some of the billionaires in the US and how much they made just in 1 year, but also across the world. In China, Germany, France, Brazil, Canada, billionaires were making so much money. And if in industries where if we really truly had a human-oriented people-first system, it would be hard to think of how you can make this many profits, for example, in the health industry, right? So this literature linking racism, colonialism, and capitalism also sheds light on conditions in the global periphery during this pandemic. Dr. Firew also already talked about this a little bit, so I won't go into too much depth, but it is really important to note that, you remember at the beginning of the pandemic, there were all these charts and graphs like this one about which countries are the best prepared to deal with this kind of virus, and which ones are the worst prepared. And when we actually look at how it played out, it was the opposite. Many African and Caribbean countries had done remarkably well in containing the spread of COVID-19 and minimizing the number of fatalities. So these predictions were defied. There are many reasons to be cautious about these numbers because of testing and tracking, but also in the US, testing and tracking was a major challenge. And on the ground, it is clear that many countries in the global periphery avoided large masses of people who were being stricken with COVID-19 related symptoms, right? And the excess death rates were not as high as they were in the US and in European countries. But we know that due to the enduring relations of colonial domination, African and Caribbean economies remain tied to the global political economy in ways that make them even more susceptible to the effects of the pandemic. These countries are in a structural position of extreme dependency on international markets, international travel and exchange. So they were very vulnerable to the spread of COVID-19 and the negative economic effects. But as Dr. Firew already said, many countries across Africa and the Caribbean, the governments acted early. They contained schools, workplaces, restricted public events and movement, and launched vigorous public health and public information campaigns, and people largely cooperated at the start of the pandemic. However, we can see how racial capitalism again structures the experience of these countries. Continued capitalist extraction compounds and intensifies the ongoing patterns of colonial domination and racialized super exploitation in these areas. These economies were badly hit by the economic fallout of the pandemic. Tourism declined remarkably, particularly the data across the Caribbean, which are tourist-dependent countries, no more cruise ships, much less flights, and so on. So the question is, how will these economies that depend on tourism and frequent travel do? How will they manage? What will happen, right? What is happening in countries that depend on remittances when workers abroad who were sending money home are now experiencing COVID-related wage cuts and salary cuts and laying off, right? Export processing zones in places like the Dominican Republic were severely impacted. And from my country, Trinidad and Tobago, right, which depends on oil and gas exports, when nobody was driving because of the pandemic and movement was restricted, there was not, commodity prices plunged dramatically. And so revenues from oil and gas plunged dramatically. So there were enormous impacts. And then we can think about the vaccine, the dependency on vaccines across the Caribbean and Africa, right? We depend on the imperial core countries for the vaccines. Just look at what is happening globally, right? All the lives that these governments were able to protect initially are now hanging in the balance. We already know how within the core, vaccine rollout plans failed to treat populations racialized as non-white at the same rates as white populations. But globally as well, North American and European countries have been hoarding vaccines, therefore preventing countries in the global south from being able to vaccinate their populations. Some call this vaccine apartheid. Another term I've seen is vaccine nationalism. But this is the situation. The US even invoked protectionist measures to hoard the materials needed to manufacture the vaccines so that producers in places like India were unable to get the raw materials needed to make the vaccines for their population. Moreover, vaccine costs vary significantly, with peripheralized countries paying far more per dose than North American and European governments. And on top of all of this, capital and international financial institutions use the crisis as an opportunity to increase coercion on peripheralized nations. So they're trying to extract even more during this pandemic. For instance, the IMF has tied some COVID-19 related loans that are supposed to be loans to help relieve the financial situation in these countries. They've tied these loans to austerity measures. And there were also reports that Pfizer was strong arming Brazil and Argentina in vaccine negotiations, demanding that these countries put up their sovereign assets, such as, military bases and embassy buildings and so on, as a guarantee against the cost of future legal cases that might stem from adverse effects of the vaccine. So the question is, while there was a race for the vaccine, the question is to vaccinate which race, right? Racial capitalism and white supremacy continue to be reinscribed and reinforced, elevating white lives, and especially white lives in the core, above others racialized as non-white. And so I'll just conclude by saying, over a year and a half into the pandemic, racial capitalism remains a stubborn system. From sickness to death to prevention, we're seeing how the long-standing structures and ideologies are persisting and becoming even more entrenched. The dominant overarching concern is how can we get back to how things used to be? How can we get workers back to work? How can we get students back to school? How can we get back to normal? It's backward looking, right? And that normal was exploitation, racism, dispossession, inequality, no job security, insufficient social services, no welfare, police repression, the list goes on. We have not been able to come up with an alternative model for education, for example. All of our institutions, our universities, I think, are just trying to just get back to how it used to be. Bring all the faculty back, bring all the students back, right? And so, how this is linked to their concern about tuition and room and board payments rather than lives is important, because that has disparate impacts on different groups based on race. And so I'll just end with this, sort of this provocation that, Black and other racialized workers in the core and periphery are continuing to be disproportionately exploited. And so the question is, in this system, do we actually want to save lives? And can we, or do we need an entirely new system? Thank you.
Challenging. So I think given the space that you're in and the fact that we're in the same space, the question that you're raising, what is normal? What do we mean by getting back to normal? And if we cannot get back to normal, it means that all the information that you provided tells us that we're in a transition. A transition to what? Is the transition to a new mode of human life? Or is a transition where Black and brown lives will be continuously be devalued? So I think there's so much in both presentations that I am going to assure you that we are going to do the best to get this out so that we'll have a very wide audience to understand this. The core morbidities. It's reinforcing the arguments that were made by this Professor Washington in Medical Apartheid. Medical Apartheid tells us about the disproportionate impact of these core morbidities on Black peoples, on poor peoples in the world. Now, the question that you have posed for all of us is, here are countries in the Caribbean that in the past depended on tourism. Can you continue to have an industry called tourism that mobilizes the majority of the people to provide hospitality and leisure for people from other society? Or is it not necessary for you to be able to build a society that is self-sustaining, that is integrated within its own borders? I think the questions that you have posed about the future of life are very profound. Many people talk about how billionaires became richer in the pandemic period. But what you've shown is the objective conditions through which the billionaires became wealthy in this period. So I think what we have today, we've had a feast of Dr. Firew giving us this personal story and your analytical framework of why we're in a transition beyond racial capitalism. That is what I take from your presentation, which I would not disagree with. We have a very, very rich audience. We have persons who have worked with the WHO all over Africa. We have professors from Syracuse University. We have students. We have faculty. So I hope you'll bear with us so that the discussion will be equally rich for today. So Mahi, I'm going to hand it over to you so that we can now start processing the questions.
Okay, well, thank you both presenters. Shukri she was tasked with reading some of the questions in the chat, but I see no questions in the chat. Correct me if I'm wrong, Shukri. So I think since it's a pretty small group, I would say if anybody has questions, we can just go ahead, raise our hands and just ask the speakers via Zoom. If you want to turn on your video, please do so. If not, just turn on your microphone and ask. Yeah, and I have a question as well, but I'll give other potential people and the participants.
So I have a question for specifically Dr. Firew. During your presentation, you were talking about COVID fatigue and the effect on frontline workers and how that affected not only mental health, but also physical health. So I guess I had a question, well, two-part question. The first is, with this mental health aspect, was there support systems put in place by the hospital system for frontline workers, and what those support systems look like, or if it was just continuing to, this idea of just keep working, push through it. And then also how now where we are at in the pandemic, looking at vaccine hesitancy, how vaccine hesitancy and the continuous population of unvaccinated people is affecting kind of this COVID fatigue, kind of, how is that affecting healthcare workers now?
Should I answer now? Okay. Thank you for that question, Jordan. So to address your first question, unfortunately, like everything else with the pandemic, the US healthcare system has been reactive. So unfortunately, after the suicide of my colleague is when there was the drive and I guess the necessity to offer help. I would say the hospital and also my department were very supportive, making psychological help available in collaboration with people that, in collaboration with the Department of Psychiatry at the school. And more so like, they offered one-to-one and also other things that were very helpful, I feel like, was really this kind of support that we had for one another. We would have debriefings almost at the end of the day, almost every day through Zoom. And also they had a lot of platforms for us to come and talk to each other, and sometimes also guided by a trained mental health expert. So that was very helpful, and this continued for people who are interested, and it is continued also for people. I also should say that the one-to-one sort of, I guess, screening in a way, or one-to-one discussion with the psychiatrist was mandated almost immediately. Some people opted out, but were really highly encouraged. You guys know what that means, to at least participate in that. And that continued. So, and even now when, I trained at NYU, and there was one nurse who recently also died by suicide, another nurse also of my current institution. And when this kind of things happen, we get those emails that says this help is available to you and available for you. So those, of course, yes, we still had to continue to work because patients had to be taken care of. If anybody needed a mental health break, that was very highly encouraged. Me, I'm always very comfortable sharing these things. And I also don't want it to make it seem like it's a self-promotion, but really is just to share what, for me, my therapy was really venting about it and writing about it. And I did that through different media outlets. I wrote an op-ed on CNN about this right after the suicide of my colleague Lorna Breen, and it happened to be on my birthday, so it was a lot of mix of emotions. So on CNN, and I also got interviewed about it. So that I did, and most of it was just me advocating for healthcare in general. We're not okay. We're not going to be okay for the long term. I've also had the experience of working in war zones and dealing with some of the trauma related to serving in humanitarian settings. By no means, I think for this importance for this platform, being an African heritage or coming from the Caribbean, and really coming from other diaspora outlook, really seeking mental health is something that's frowned upon. And people will tell you to pray or go to church, mosque, whatever, but really normalizing that it's okay to seek mental health, and that it's okay to have Jesus and have mental health too. So that's been kind of what I've done personally to advocate for that. And for me, everybody have their own way of dealing. For me, I think it's just, in addition to what's going on with the pandemic, also personally with what's happening in Ethiopia with the war and stuff, there's been so much happening. So for me, I think it was kind of a blessing to have my son. So he's been my good distraction. And really, it's just been very helpful to, have such a phenomenal supportive family, including my own family, my husband, and really my own work, and really working for advocacy. And that's been, people have waste, they deal their stress. And for me, it's just been really advocating and also writing about it. And also, when you write an advocate, I think it comes, you need the evidence for it. So it was really with anger, I actually did the research on two things. One was on healthcare burnout and our mental and psychological health. So it was published on BMJ. We surveyed over 5,000 healthcare providers, 3,000 healthcare providers. And it's on BMJ. If you Google me with my name on studying specifically on the mental and psychological effect of COVID-19 very, very early on. Afterwards, there's been vast studies about that. So really, when you're trying to do this outreach and advocacy work and to talk about it and blah, 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 it doesn't help if you don't have the evidence. So for me to show that really this anger-driven work, which I was able to do. And the other thing is what Dr. Edwards talked about extensively is to see people that look like me dying disproportionately in the emergency department. Also, even when people come with a lot of privilege, as a physician, you would think that I have good access to care, all this, but there's a lot of things that within our institution, such as structural racism and all of this that we deal with. And people that look like me, whether they came from a privileged background or they're educated or have access to healthcare, they were still dying disproportionately, in addition to the people that were dying that came from low socioeconomic status. So I also did the research about that and wrote about it extensively. And of course, Dr. Edwards has shown all of the details, and she has a much more profound work on that. And that was very informational when you presented. So really just putting these things on visible. You'd be surprised by it. Like, I think this pandemic has shown me how people are under informed, or they're just misinformed. And you would think that the little bit of biology lessons that they had in high school or something would help. But I think really just talking about it and trying to be the voice of reason to share this information and to share, even people, I have seen patients who they're like in their 70s, 80s, and they've never seen a doctor. So just to have that one-on-one, and I've made myself available for many people, just like, hey, if you have any questions about vaccines or anything, I can be available, which is kind of a segue towards your second question. Even though I'm not a big fan of this, there's this word, the pandemic of the vaccinated and the unvaccinated. It shouldn't be that way. I think we should all take a holistic approach. And we're seeing that disproportionately, even amongst healthcare providers. And you guys know that recently, and I'm a big fan of that. I went out and spoke about this, that New York City mandated healthcare providers, frontline workers to get vaccinated. And that's been, a bit of a challenge for many people. And that's why there's some nurses and healthcare providers that have left the workforce because they do not like the mandate. So, yeah, we're seeing that, and we're seeing many, many more people who are unvaccinated, and most of them are unvaccinated because of wrong information, or they just don't have access to it. And I also did, out of anger, again, I also did a study looking at vaccine hesitancy for patients that come to emergency departments, because that, which is something that Dr. Edwards highlighted in her study, that most people is really about access to care. So we see that people, especially in my emergency department, where Black and Hispanic use the emergency department as a source of their primary care, you realize that they haven't had the opportunity to talk to a healthcare provider about this. But when they come for a broken ankle or, other non-COVID related symptoms, you'll talk to them about, hey, have you been vaccinated? And we've offered the vaccine in our emergency departments and all over New York. So really using that opportunity to teach them. And at least from the preliminary of the data, we surveyed close to 500 patients in our emergency department. A lot of people who get their information from social media are hesitant about the vaccine, versus people that have access to primary care, who are insured, who are educated, who are well plugged into the healthcare system. They have more positive thoughts about the vaccine. So you see this, I think, it's not really vaccine hesitancy for like the right word, but it's really about the lack of vaccine information, or the lack of the right vaccine information. And Kizzy, she from NIH, now I guess from Harvard, she's highly spoken about this. Like, you know, she said, I don't think Black people are hesitant about vaccine, but they're just inquisitive, and we have to teach them. That's her approach. And that's been the case. And of course, you also see that disproportionately right now, but we're seeing that more Blacks and Hispanics are getting vaccinated, especially in the South compared to the white population. And you're seeing that a lot of the unvaccinated people that work, that, you know, my colleagues that work in Florida and then Georgia have reported to me, a lot of the unvaccinated individuals who are being hospitalized are white people who, because of the political division and the source of their information and the resistance, are unfortunately the ones in the ICUs and in the hospital. So it's just amazing how misinformation could lead to almost you dying and having your family people die from it. So I hope I answered your question, but just a long-winded answer of yes, we did get help, and yes, the unvaccinated is, the pandemic of the unvaccinated is very stressful and fatigue-inducing.
Thank you, Dr. Firew, for your response and your insight. Next, we have a question from Dr. Smith. Dr. Smith, are you able to unmute?
Yes, sorry, I'm having internet problems, but, and I'm on campus. Professor Edwards and Dr. Firew, thank you for, as Shukri said, very insightful talks. I guess to preface my question, Professor Edwards, you really show how COVID-19 demonstrates how diverse economic factors come together, converge to influence health and well-being, and how, you know, the current eco-political systems that we live in and historical phenomena really have provided this framework, which shows how COVID-19 extends like excess morbidity and mortality within Black and other marginalized communities. And so my question is for Dr. Firew. If we know that vulnerable residents of these communities endure this underlying heavier burden of chronic disease, and it's related to socioeconomic and political and medical fissures, my question is, knowing the fragility of the healthcare system of medical institutions, what has changed beyond the individual level within the medical establishment, within healthcare systems, to strengthen them to not return to healthcare as normal, to be more, I guess, prepared to meet the medical needs of these more vulnerable patients?
I'll say a bit, but I think Dr. Edwards also should probably say a bit about this. I'm pretty sure she has a better insight about it. So, Dr. Smith, I do, at least from my point of view, and from my, I'm not trying to be pessimistic, but really being a realist on this, is my answer is nothing, unfortunately. At least nothing tangible yet. And at, you know, the micro levels, at hospital systems or at, you know, city levels, some things could be placed, but we know that's not going to be sustainable unless we take a holistic and a federal approach. And the biggest thing I would say is just the healthcare system in America, for lack of a better word, just sucks, especially when it comes to being one of the, you know, the developed nations, and compared to what we're seeing from, you know, in Europe, in some countries in Asia, Australia, all of that, the US system, healthcare system has just failed us. And, you know, in a way, I'm not trying to be political with this, but I felt like the, you know, the Affordable Care Act was kind of the gearing in the right direction towards universal health coverage, which is something I believe in and advocate for. So unfortunately, the root cause and the real problem is really about access to care, universal access to care. And if we're not working towards it, then we can't achieve a healthcare equity everywhere, and the injustices will continue. So I will tell you this at an institutional level, which is what we probably most of you guys have seen, not only because of COVID, but in the wake of what happened to George Floyd, you know, really this agenda for equity. And I say this for the lack of a better word again, but now all of a sudden everybody's woke and trying to do this healthcare equity and establishing a justice center and all of those things. And everybody's trying to assign a vice chair or dean of, you know, equity. Those are all, you know, great things, but they have to be sustainable. And are we also putting people of color in those positions? Or are we putting, and unfortunately we've seen that people who don't identify themselves as a person of color are in these positions. Let's look at research fundings. Research fundings for this kind of work has been driven by white individuals, and unfortunately is not inclusive. So, and I always say this, most academic institutions are working towards it. And it's great to see this positive change, but I feel like it's going to take years and a lot of advocacy. And I say this to a lot of my young mentees and to a lot of the younger generation. It's really important to be verbal about it. You know, people say I hate politics, but it's important to get politically active. And more than so anywhere, after finishing medical school, I did a fellowship, and just like you guys listened to my bio, I also did public health. And the reason I got geared towards policy work is because I felt like high level decisions and I could do impactful work if I get involved in policy. It was never because I liked politics or policy. And I think it's just really having the right people at the right place who will advocate for the right things. And that won't happen unless we're loud, and we're, most of you guys, I say that because I'm not a US citizen, I don't want to give up my Ethiopian citizenship, but because most of you guys should start running for you know, political positions and advocate for those people. At least the least a lot of us can do is vote. So so I think to give you the answer to that, Dr. Smith, is there's some minor change. Let's see how long they last. And it's going to be, to have a sustainable change to address these things, it's going to take more than anything right now is politicized, and it's for the wrong and right reasons. So I would say that it's very important to push for those two things simultaneously, and to see this equitable access to care. And one thing I will add to that, and also in my research, and I think as Dr. Edwards could allude to, once patients come into the hospital and they get access to care, no matter what socioeconomic status or what race, ethnicity they belong to, once arriving to the hospital, most of the outcome has been the same. It's really what happens pre-hospital, before arriving to the hospitals. Once they come in and you expose them to, you give them all the resources at them, they're most likely, and you control for their age and for their comorbidities, the outcome is similar. But if you look at what is happening before coming to the hospital, people are dying at home, people don't have insurance. Like Dr. Edwards said, people are, you know, still essential workers, going to work sick and taking care of family at the same time. So it's really about access to care and exposing everyone to same resources, or at least equitable distribution of resources.
Thank you so much, Dr. Firew. I absolutely agree with you.
Thank you for the question, Professor Smith, and thank you, Dr. Firew, for your answer. Professor Edwards, do you have anything you'd like to add?
I agree with all of that. I think that I definitely agree with all of that, that it is sort of worrying, troubling that after 2 years into this, we still seem to not have learned too much. And so that is really concerning, but we're also seeing, even not within healthcare specifically, but in other areas like social welfare, we're seeing even sort of a doubling down on previous policies that we know fail people and we know cause people to be marginalized in all different kinds of ways. For instance, that the CARES Act, that $1,200 that everyone was, that the US government was giving at the beginning, of the pandemic as a relief, it excluded undocumented workers in all industries, including in food production. These are the very workers who were being the most exposed being very exposed to the virus. And at the same time, it had a number of provisions within it to grant enormous relief that further enriched corporations and billionaires. And so the same thing in the UK, they offered welfare provisions to the population during the pandemic, but there's a clause, the no recourse clause, something like this, which bars immigrants from being able to access financial support and social support from the state, even in the pandemic. So I see these efforts as sort of doubling down on these very issues that caused the problem in the first place. And so, just like that.
Thank you so much for your answer. We have one question in the chat from Natalie Gallagher. She asked, what are some of the radical possibilities you saw practiced or emerged more during the pandemic that could be particularly transformative? And I believe that question is for either of our speakers.
I guess for me to start, at the medical practice level, we were able to at least witness this really collaborative approach, multidisciplinary approach towards patients' safety, especially upon discharge. This was not something that was common in practice. We'll send people home with oxygen and with, pulse. So we made those things available in our emergency department. And that was something that, would never happen before. And I think also speaking from more of a global context, also in Ethiopia, I would say making things such as oxygen pulse oximetry to measure your oxygenation. It's been kind of a practice that's widely used. And in addition to that, the Minister of Health of Ethiopia was just talking about today on the PAS presentation, how availability of oxygen and oxygen plants being established in most of the most sub-Saharan African countries, I think is something transformative, because it's oxygen, we know it's, it's not only for COVID, there's been a national shortage of oxygen for different treatments, especially for child pneumonia and other things. So this wide availability of oxygen at lower income countries has been very widely helpful. Another thing I would say, I think the drive for COVID pandemic vaccine and the really all the resources that were generated for COVID-19 vaccine has helped expedite the development of other vaccines, such as for HIV, malaria, those things. And I think that has been something that we've learned from this pandemic, especially such as mRNA vaccination, development of mRNA vaccination, even though we have 20 plus years of research on mRNA vaccination, but using the data now to develop that, having the technology to develop that in a matter of a year after you have the sequence, it's something I would say big and transformative. And I would say it's one of the biggest innovative and life-saving approach that we've seen being developed for other things besides COVID. And one last thing, especially in the sub-Saharan African context, as you know, and I think Dr. Edwards also touched a bit about this, are the challenges of resources for dealing with COVID pandemic in general, where there's been a lot of reliance on the previously colonial countries to provide medical aid and vaccines and vaccine appetite and vaccines hoarding. But now there's been establishment of vaccination centers and research institute and sub-Saharan African countries, which is a huge and a colossal move for development of vaccines and local production of medications and vaccinations. I think that would help also enhance for future pandemic, there is the response for future pandemic, and also for pandemic preparedness is really about sustainability and local production, which is something that we lack. And so much of it has been really relying on donations, unfortunately. And one thing I would say, I know when we talk about vaccine hoarding, in addition to what Dr. Edwards was mentioning, I'm not sure if you guys know the COVAX vaccine initiative through WHO and Gavi. Some people feel like, I don't know what to do for vaccination efforts for low and middle income countries, but if you go to Gavi, which stands for Global Alliance for Vaccination and Immunization, people can individually donate towards vaccine for to support for low and middle income countries. Still, a lot of it's higher policy level decisions. Those are things that you can do as an individual. For me, I made the executive decision not to get the booster, to say I feel like that's vaccine hoarding. I don't need it. There's no evidence to show that it will save me from being hospitalized or from dying just by adding a booster. And I also wrote op-eds about this to show that the data from Israel and the data for what we have so far is for people over the age of 65 and for people that have other comorbid conditions. But I am not in agreement, it's just my personal opinion, that this needed for me and my healthy colleagues to get booster right now. I think that just perpetuates this vaccine hoarding and vaccine appetite. So that's been my approach, but I think that's all of us can do something about that. So I think some of the things, hopefully I answered your question, Natalie.
And I will also say too that we've seen, I think, at least in other countries outside of North America and Europe, I'm not particularly sure what kind of radical alternatives emerged here. I'm sure there are, but I'm not aware of them off the top of my head. But across many Caribbean countries, for instance, you saw that communities started relying more on each other during the pandemic. And I think, there is a really interesting study that was written by Dr. Patricia Rodney, which was comparing the healthcare system in Barbados with the one in Grenada. And Patricia Rodney actually is the wife of Walter Rodney, the late Walter Rodney. And she was showing how, a more people-centered healthcare system like the one in Grenada was much more effective in treating people, but as well as sort of disease prevention and so on, than a more Western style looking healthcare system that existed in Barbados. And I think the pandemic offered an opportunity for countries to rethink sort of what healthcare delivery could look like, and to elevate people over sort of corporations and profit and even governments. And so there's a lot of organizing around that. At the same time, I still think there is that opportunity I don't think it's gone away, but even we see with vaccine resistance and vaccine hesitancy, how can we get more people who are vaccine hesitant, who don't want to take the vaccine, to do so? And Dr. Firew gave a rich number of examples, but also, you know, how can this from communities as well, using more community-oriented approaches, how might that be useful? And so there are sort of, I think, developments in those directions for people relying on each other. There's been a lot of organizing, I think, in countries like Kenya and so on. We've seen farmers and so on organizing. So there's a lot of rich activity that's still going on. And I guess we will have to see sort of how it comes together. Yeah.
Thank you both for your answers and your insights. And we have one question from Professor Martin. There you are.
Thank you. It's actually not one question, but I think I'll make it two. And before I do that, I want to really thank Dr. Firew for your very personal sharing of what you had to sort of experience, you know, during the first wave of the COVID pandemic in New York City. That's quite very, you know, very important in many ways. You know, it helps to be able to kind of bring home the realities of what this is like. And then, you know, just being able to tell, you know, the truth about how COVID is such a serious, you know, problem. So we really thank you, or I personally really thank you for sharing those personal stories with us. But also it speaks to your resilience as well in being able to kind of, you know, help the way you helped. And thank you so much, Dr. Edwards, especially for a very informative, you know, explanation of the long arc of the relationship between capitalism, racism, and inequalities, you know, both within national borders and globally. I think I really enjoyed listening to that, especially the extent to which capitalism profits from social production of difference, which, you know, brings about or tends to expand the realm of racism, and how that becomes a problem locally and globally. Now, I was thinking that Dr. Firew, you've sort of given an exposition a little bit on how, especially Ethiopia has been pretty successful, I would say, in, you know, handling this problem of COVID. So I'm wondering, especially what specific measures the government has been able to kind of adopt to make this to be, you know, some sort of a relatively successful story. I remember you sort of indicated the fact that part of the success could be because of, you know, the younger youthful population in Ethiopia. And I'm thinking that, you know, in as much as, I don't think I'm a medic, but I'm also thinking that the so-called Delta variant in particular, we are being told that it is no respecter of age, so to speak. So the younger population might be receiving the, you know, the hardest part of what Delta variant can deal to them. But looks like Ethiopia has succeeded or is succeeding. And I'm thinking what it is that the government is doing that could provide some sort of a roadmap for other African countries. And specifically, I'm thinking about Tanzania, Burundi in particular, where the problem has been quite a major issue. Now, Dr. Edwards, you indicated a little bit about the impact of, you know, dependent economies. You know, and, you know, how this has exacerbated or how COVID has exacerbated problems in those specific economies, specifically tourism, which you indicated is, you know, is so much a part of, you know, the Caribbean, you know, a political economy, so to speak. And I agree with you that, you know, tourism has perhaps suffered the most. Now, specifically for African countries as well, I can speak for Eastern African countries in particular that I'm quite very conversant with respect to how tourism has been a number 2 income earner to agriculture for decades, right? So I think you are right on the point there. But I was going to ask that, and perhaps Dr. Firew can weigh on this at the second question as well, which is that in our discussion of COVID and Africa as of now, I'm thinking that we might be lost to some good news that has come from down there the last, I think, 2 or so days about the rollout of the malaria vaccine. Now, in as much as it is not so much related to COVID, but I'm assuming that malaria, the problem of malaria has perhaps been exacerbated by, the COVID pandemic, but there has been a rollout of malaria vaccine. And I'm thinking, Dr. Edwards, if you can weigh on this a little bit, if there is this danger that the patent or the patent and then the supply of the malaria vaccine, which, as I understand, it has been produced by African scientists, right? Or so to speak, it has been produced by African scientists, collaboration between Ghana, Kenya, and Malawi. And I'm thinking that, are there dangers that, the patent and supply of the malaria vaccine is likely to be appropriated by global capitalist impulses, especially in the production and supply? Now that we know what global capitalism and inequality can do to be able to minimize or even undermine the supply of, life-saving equipment and material. In this sense, I'm thinking of vaccines to the global south. Thank you. I'm sorry, long question, but a little bit more winded, but thank you.
Could I make a suggestion? Could I suggest that we take 2 or 3 more questions and comments, because I see my brother Halem here, and I know he wants to say something based on his experience with Gavi. And to ensure that we respect time, could we take 2 or 3 questions together before we ask the speakers to respond?
Yes, we certainly can. So we'll take questions, and hopefully our speakers are able to take some notes while those in our audience give the questions. Okay, so we'll have, you said?
Halem.
Halem, okay.
Hello, thank you, Professor Campbell, and thank you to the speakers for this. Can you see me? Sorry about that, I'm on campus. So thank you so much for the speakers as well. It's a very rich conversation. From my side, I actually used to work with WHO, and I was the crisis communications officer for WHO in the Afro region. And basically, briefly, what I was doing was focusing on vaccine hesitancy, which is the topic of the hour. And there's a lot, and specifically on misinformation and why, African communities are skeptic about taking the COVID-19 vaccines. That has been rooted in a lot of problems, such as the issue with Africa, the campaign that came out earlier during the pandemic, like Africans are not lab rats, in response to some comments by the French doctors, and there were a lot of other issues. I think just briefly on misinformation, there's a lot of misinformation that is targeting African countries and African communities that are actually starting here from the United States. The kind of conspiracy theories and anti-vax profiteers are actually producing messages that are resonating with some of our communities on the continent. Also, there is a lot of agency as well that we have, and for communities and for governments in the African continent. I think there's also, when it comes to when there was a mention about the COVAX facility, and I think one of the most important things to know is that we were not ready at some point. I mean, we've done better. Our countries have done better, but the preparedness levels of countries like Ethiopia and Nigeria, Kenya, is something that cannot be compared to other countries like Mozambique, for example, or I mean, it varies for sure. Or South Sudan, for example, or other countries. But the issue is that, and I'm sure also the experts on the panel also know that it's a very rigorous process that requires a lot of paperwork and preparations and clearances, and especially when rolling out a vaccine, we didn't have the flexibility to roll out in terms of regulatory authorities on the continent. That was a very big challenge. And the fact that the vaccine hoarding has been the case in the beginning, the fact there are two elements, in my opinion, my humble opinion. The fact that we were not ready to absorb the vaccines right away, and the fact that the pharmaceutical companies did not actually sign the final deals with the WHO and the COVAX facility, and they started taking the money from the G20 countries right away and did bilateral deals. And the fact that there has been bilateral deals in the first place has been a fundamental issue to the reality that we're living today. I feel that the discussion has been extremely insightful on a number of levels, and I'm curious on the issue of capitalist racism and that Dr. Edwards was talking about. I'm wondering, maybe just to play devil's advocate, but like, isn't it an issue with the so for example, if we talk about the US, regardless of race in the US, the vaccines have reached many people from the African American communities, from the Hispanic communities. So would you still consider that as a racist issue, because people in those countries would still get the vaccines from different minorities, and they're actually prioritized? I mean, there are, of course, these issues with African American communities, with Hispanic communities, American Indian and Alaska Natives, and all of that. And actually, we're working on research on the AAI and communities, and better understand their vaccine, their perception about vaccines, and how would that impact, the rollout, especially for the children in the coming phase. But just wanted to know your thoughts on this point.
Thank you for your question. And then we'll take Mahi's question. Mahi, are you able to unmute?
Yes, I am. In a way, my question has kind of been touched on by both speakers. I'm not sure, Amy, if you have a question, but generally I wanted to kind of highlight, like Dr. Edwards, your presentation showed us that this concept of normal is abnormal, especially to people at a particular intersection of race, class, and gender. And so since both of you are in academia, I wanted a general, how do we transform the concept of normal within academia, right? Because it's a regressive concept we're trying to get back to. So what is our goal? And for people like most of us here are in academia, like how do we envision what the new normal is? But I know we don't have time, so feel free to go back to that question last, as all the other participants have asked important questions.
Yeah, I also have a quick question. Mine is more about resistance against this racism. So I'm going to ask, for Professor Edwards, how did the COVID-19 show that the movements like the BLM, that the centrality of such movements have to be global, not only against racism, but against this capitalist mode of production that requires the Black worker, but still treats them as expendable? You can also go to my question last. Unfortunately, I have to go, but I'll be sure to watch the recording and hear your answer. Thank you.
Okay, so we'll start with these questions for now with our panelists. So we'll start with Professor Edwards and then go to Dr. Firew.
Good, thank you all so much for these questions. I'll start, I guess, with Dr. Martin's question about the malaria vaccine. And I totally agree with you with sort of what we should be thinking about as this vaccine, as we start to think about production and mass dissemination of this vaccine. Because when we look at what happened with COVID, with how the COVID vaccine was developed, we can easily see a similar story unfolding if we're not very careful about how this is all organized. So the scientists who developed the COVID-19 vaccine are international. They come from all over. They're Turkish, right? So there was a lot of brain power, so to speak, that came together to develop the vaccine. But then in the end, the global South still, as Halim was, describing, sort of waiting they were at the least prioritized, while rich countries made bilateral agreements and so on. It might be a little bit different given that malaria is less of a issue faced in the global North. But I think in terms of patterns, where production is located, all of those things will be really important, because when we look at India was one of the centers that was very much involved in producing the COVID-19 vaccine, and they couldn't even get it to vaccinate their own population. And so that whole thing is really concerning, and I think we will have to really watch and be careful about how this is all organized, so that it doesn't repeat itself with the malaria vaccine. On the question of what is happening within the US with the vaccine rollout and minoritized populations in the US, at least the data that I've seen so far is that actually minoritized populations are not being vaccinated at the same rates as whites. They are perhaps having higher rates than maybe other parts of the world because the vaccine is here, but there are wide gaps in cities like Chicago, and it's also in rural areas, huge gaps between, at least in the beginning when the vaccine was being rolled out. And I know this is sort of a temporal thing because over time, more and more people get vaccinated. But I think there was a real structural problem with vaccine dissemination where white Americans were being vaccinated at much higher rates than Black Americans, even though they have very similar rates of vaccine hesitancy between the two groups. So it spoke to access and how minoritized and racialized populations in the US really had difficulties accessing the vaccines when they were first rolled out. And that kind of mirrors what we're seeing, globally as well. In terms of transforming, I'll just really quickly, transforming the concept of normal in academia, I think is a really important one. We can say this with respect to the COVID-19 pandemic, but also just more broadly speaking, there are all these moves to decolonize, right? Decolonize the curriculum and all of this. And I wonder if we might need to, if we should, which is decolonizing the curriculum is important, but really thinking carefully about an anti-capitalist curriculum. What does that look like? And why don't we use that language? Because if capitalism is racist, right? If capitalism is, gendered, why don't we talk about an anti-capitalist curriculum, which I think shifts the frame a little bit, because then the university cannot exist the way that it exists. And that's radical, that's different than, I think, pushing more boundaries, than decolonizing the curriculum. And I'll stop there. Oh, sorry, I just with the Black Lives Matter and the global question, just really quickly, I totally agree. It can't be it cannot just be a localized solution. It has to be global because capitalism is global, right? And this is the Pan-African, I think the Pan-African tradition that Dr. Campbell is talking about in the beginning about, you know, what this forum is all about, right? Is that it has to be global because this is a global structure and a global problem.
I agree with everything that was said already. I don't think I have much to add, maybe just to mention what earlier what Professor Martin asked about Ethiopia, the Delta variant. You're absolutely right. The Delta variant now is more also deadly when it comes to young, especially children too. We've seen it disproportionately compared to the prior variants. And even with that, I would say though, I think a lot of people with comorbidities and that have that are over the age of 55 are still at a higher risk, even to with the Delta variant compared to the younger population. But absolutely, the Delta variant is much more deadly than the Alpha variant, even for younger generation. And in addition to, in regards to what you said about the Ethiopian, what has worked initially well, I think was mentioned earlier what from Professor Edwards' discussion and presentation, really it's the poor man's medicine is prevention, and really what has worked well in Ethiopia is really the NPIs or the non-pharmaceutical interventions. Even school closures happened. Not a big fan of school closures because I know it comes with a lot of unintended consequences, but really mass gatherings and school closures happened way earlier before we even had a case in Ethiopia. It was detected. We presume there was some community spread that was not detected. So, and the numbers, you know, for me, it's yes, of course, compared to most of the, you know, what's happening in the USA and what's happening in other parts of the world, the numbers in countries like Ethiopia and the general global South is not as deadly as we expected, and it could be because of, I mean, definitely 2-3 different things. A, the younger population, but also it's in a way it's not well captured because of lack of testing, and also because the routine surveillance and routine data gathering is poor. So that is going to be a challenge. And the true deaths and the mortality and the morbidity of COVID, because, you know, data is so limited, especially what's happening outside of the capital cities and the rural areas, we're not going to be able to actually know the true impact of COVID in some places, and including Ethiopia. So yes, we're doing the testing, but not with the way that we wanted to do so as recommended by WHO. I was just looking at Ethiopia right now, as of today, there were close to 3 million tests done since the pandemic started, 3.5 laboratory tests. So, and you look at that, and then there's 5,000, close to 6,000 dead, and total cases are 353,000. So that gives you about 10% positivity rate, which is not, you know, in general, but we're also seeing that daily we're doing between 8,000 to 15,000 tests, which is not enough for a country of close to 110 million. So it's under testing. It's quote unquote the younger population that's protected, but we also know that we've seen in the US too, there's COVID mortality, but there's also COVID related mortality, which is related to mainly because of just the shortage of ICUs and hospital pretty much being overwhelmed. Their death and all case mortalities have increased in most places in the US, and I would assume that is in most of the African countries. So that, I think I answered those questions, but I think everything else that has been asked, I don't think I can add anything in addition to what Professor Edwards said. I agree with all the comments and all the answer that he provided. So for the sake of time, I'll stop here.
Thank you. Thank you to both of you for answering my questions. Thank you.
Well, what can we say? I we have gone 3 minutes over time, but I think we need to take a minute to thank everyone. First, I want to thank all of those who participated in this discussion, and we want to invite you to work with us in the Africa Initiative. And Halem, now that you've seen what we're doing here, I hope that you will bring all those other brothers and sisters into the Africa Initiative. Our next event is next week, Friday. We have a graduate, undergraduate students discussion. And this discussion will continue because the question that was raised about decolonizing the curriculum or having an anti-capitalist curriculum, that capitalism is racist. Professor Edwards has pointed out very clearly that they're doubling down with what they call diversity and exclusion and decolonizing the curriculum instead of dealing with racism, capitalism, police violence, and health disparities, not health disparities. So next week, and this will be in person. I think we may have it in Simsol. We'll let you know the venue, but please advertise. I must say that faculty is not invited to this event. This is graduate students and undergraduates. And food will be present because we want the African students, Africana students to be able to speak freely without faculty being there. On the 22nd of October, there'll be two events, one at 4 p.m. Oh, I'm sorry, one at 4 p.m. Alternative Views and Descriptions of African Languages. Dr. Christopher Green, in the Professor of Linguistics and Language in Syracuse University, and that will be in Sims 219. So I look forward to all of you joining us. I want to thank the team that worked on this event, and I want to thank the students and faculty. I did not mention some members of faculty from Africa Initiative were here, but they know who they are. Ray, Professor Campbell, Professor Martin, Daniel. But our students, Jordan and Amy, and Shukri, thank you so much. And of course, to our coordinator between the graduates, undergraduates, and faculty, Mahi, who was persistent to work with to ensure that we had such a good program today. Now, I want to say how heartfelt thanks we are. We cannot express our thanks to our two speakers. Not only was the presentation rich, but it deepened our understanding that we cannot go back to what is called normal. This pandemic it is unspeakable what is going on, and that people are planning to get rich and richer out of it, and to ensure that we go back to those conditions that we saw last year. It's not something which we can sit idly by. So let me thank you both very much, and let me say that we in Syracuse are going to have to find some ways of reciprocating. We have a master's in Pan-African Studies, and we want our students to work with both of you. I'm sure our students will come to you, and we hope you'll be working with us. And in any professional way that we can work with you and network with you and work within our communities, let us thank you very much, because some things are more important than money. Some things we are building for long term. And our long-term goal in the African Initiative is to create a cadre of intellectual, scholarly activists who will take us beyond the normal, what is called the abnormal. So Dr. Firew and Dr. Edwards, I would like, on behalf of all of those in Syracuse University, especially those in the community who came out and in African Tip, to thank you very much for your presentation today.
Thank you so much. Thank you.
Thank you guys, appreciate it.
Any last word, Mahi?
Nope. With that said, thank you, everybody. I will add everybody's emails to the mailing list, so we will be in touch. And thank you again to our speakers who did not hesitate to come on today.
Have a good weekend.
Yes, have a good weekend, everybody.
Zophia, unmute yourself.
Professor Campbell, yes. I'm so happy to finally meet you.
Yes.
I've seen you speak before, but I never got the chance to meet you. So I'm so happy to have this opportunity.
Okay, well, we're going to be working together more. There's so many places that we should put this show on. I don't know if you know about NCOPS that's going to happen, National Conference of Black Political Scientists. So you should really think of doing this show there so that your work can get much more airing, especially that article that you've done. So put it on, and you can talk to Mahi and I about how Helem and you, and I don't know if Dr. Firew could be there. The National Conference of Black Political Scientists from the 10th to the 13th of March. It's going to be in Baltimore. So let us email and talk about how we can put this on the road and get going with this, so that we can put forward the work. Because what I like about what you're saying is that you're going beyond all this postmodernist talk about post-colonialism and decolonialism and decoloniality. So see, we have to deal with racism and deal with these questions. So I am very pleased that you're pushing those boundaries, that this is anti-capitalism, because what we're facing in the university is an assault on us to say that we're dealing with diversity and exclusion and not with the real questions.
Absolutely, absolutely. Yes, yeah. I'm really excited for this collaboration, these future collaborations. And yes, I mean, our college here, it's just endless. That we brought, students back, and the rates of COVID, we're not really testing. It's just like we're not kind of in a pandemic anymore. We have to wear masks, but students are partying and so on and spreading the disease to the community. We're in a working class neighborhood, and it's just again this backward looking kind of frame that everybody's coming with is so problematic. So hopefully we can push more, encourage more, creativity to these solutions.
Yeah. So thank you. So we'll be in touch.
Thank you. Have a good evening. Have a good weekend.
Have a good evening.
Dr. Edwards,
Yeah.
thank you again. Hi, Africa Initiative team. I'm gonna put Charles in the waiting room.
Huh?
Mahi,
It's
are you
Charles.
still recording?
Charles,
Oh
are you
my
there?
God, yeah.